area where we are operating. Okay, the depth of the wound, like we are operating in the oral cavity, we need a larger instrument. We are operating in the abdomen, we need a larger instrument. But in a surface surgery, like skin, a shorter instrument is useful. Okay, and like non-tooth forceps we usually keep for very delicate tissues. Like using a toothed forceps can damage the tissue. Like in microsurgery, where the vessels are very thin, they are very delicate tissue. You cannot grasp the tissue with a tooth forceps. That will grasp the tissue and damage the tissue. So in that areas we use non-tooth forceps. Okay, very delicate areas. And also there is a forceps called DBK forceps. That is a vascular forceps. We call it a vascular friendly forceps. So if we use a DBK forceps to hold a blood vessel, the chances of damaging the blood vessel is very less. And skin hook, there is an instrument called skin hook. We can retract the skin, and that also in certain area that we cannot hold the area with any type of forceps. Skin hook we use for the traction and giving the suture. Then come the needle holders. Needle holders to hold the needle. Okay. Needle holder can be same, the length, micro or the macro, depending upon the area where we are operating. There can be a locking or non-locking type of instrument, but most of the time we use locking type of instrument. Okay. The tip of the needle holder is also very important. The tip can be broad tip or fine tip. Okay. So when we are holding up a large needle, a thick, broad, large needle, then we usually use a broad tip needle holder or heavy needle holder. We call it heavy needle holder. So it has a more power. In case of we are holding a small like 506 sutures, number of sutures, the more number the suture is, the thinner and the needle will be more smaller. Okay. So in that areas we usually use a smaller or thin type of needle holder. And then comes the stitch cutting scissors. Stitch cutting scissors, the length is important depending on the areas where you are operating. It can be straight or curved. Okay, it can be micro scissors or macro scissors. Now the needle type. The needle type is important. Usually there are many types of needle. Okay, the shapes and all. But most of the time, as a surgeon in the OT room, we usually call it round body or cutting body. These are the two types, round or cutting. Cutting has three types. Okay, but most of the time cutting usually reverse cutting and normal cutting. Okay, conventional cutting. So two types, and another taper point is round body. So round body we usually use in case of mucosa when there is a less tough tissue, it's delicate tissue. We usually prefer a round body. Cutting body when there is a tough tissue like skin. Okay, we have to cut through the tissue. So in that areas like skin, we usually prefer using a cutting body. Needle can be straight needle or round needle, but the most of the cases we usually prefer round needles. Okay. Curvature of the needle is also very important. That we will show you the packaging that comes with the needle. So there is everything is written, the number, the length of the needle, the thread. Okay, it is round body or cutting body. Okay. So and the curvature of the needle. Curvature of the needle is important because it also depends on where we are operating in oral cavity, or if we are using a cleft palate surgery. Okay, we need a more like 3/8, 5/8, 5/8, narrow or 5/8. So most it will be almost round 5/8 circle. Okay, or half circle we commonly use. Okay, it depends where we are operating. So these are the types of the shapes of the needle. Okay, you can see the reverse cutting or conventional cutting, spatula cutting. Spatula is a flat type of needle. We usually prefer in orthoplastic surgeries. Taper cutting is there, taper point. blunt point in like kidney surgery, kidney or liver, but tissue. Okay, and this is the suture that comes with the packaging of a suture, and everything written here you can see here. This is the 50. So the more the number, the thinner or the that thread. Okay, it starts with 0 and goes up to 12 0. Okay, it is a 50 we commonly use in a cosmetic areas like face, where the skull should be as minimum as possible. Okay, we usually start from 5 in face, 5, 6. Okay, 5 or 6. Then comes the little length. There is a 19 mm length, 3 by 8 circle. You can see here. This is the cutting body, and it is written reverse cutting. Reverse cutting means if a needle like this, it has an inner curvature and an outer curvature. The reverse cutting means the cutting surface will be on the outer surface, and the conventional cutting is the cutting will be on the inner aspect. Okay. Reverse cutting is more beneficial because it has a less chance of tissue cut through. Because when we are pulling the two wound edges together, there will put some tension. Okay, so there is a chance that suture cut through the tissue. So the reverse cutting has an advantage over that. Reverse cutting has less chances of cut through the tissue. Okay. And here is the expiry date. Suture length is important. Okay, 18 inch, 45 centimeter, and the 80 long, as I mentioned, this is a non-absorbable suture. 80 long. So these are the things we have to check before we go for any picking up any suture medical. Okay. So now I am coming to the clinical presentations. Clinical presentations. I will show the continuous suturing here. Okay. So this patient is from Afghanistan, had a bone blast experience, a bone blast, and you can see in the CT scan there are some radioactive material inside the antrum. Okay, he has lost his both eyes, and there are some particles inside his that wound. So when we expose the area, was inside the antrum, and that was taken out, and also he had some stone-like things inside the eyes that we all had removed that. And so these are the things I had removed. You can see there are granulated tissue. This is a tube, and these are that stone-like particles. Okay, blast particles. And now the closure, you can see this is a continuous suture. You can see a continuous type of thread is going to continuous manner. There is no knot. Here is one knot and here is one knot. So in the middle there is no knot. Also if you start from here, you will see here is a knot. And another knot is here, that is called to strengthen the wound. Sometimes we give a continuous suture. Okay? But continuous suture has a disadvantage that it is a tendency, if it opens up, it will open in a full length. So we sometimes give some one or two interrupted sutures, okay, to hold that, to reinforce that one. Now coming to interrupted sutures. So this boy had a massive road traffic accident. Okay, he had a diploping type of wound from starting from tip of the nose, going to the medial canthus of the eye, up to the temporal region. Okay. So he came to me. The area was full of pus. Okay, full of pus. And if you see the CT scan here, the right side of the orbit and the zygomatic bone is completely shattered. Okay. So this is the after we had elevated the flap. You can see the only eye probe is on the bone, and there is no bony, the three-dimensional structure of the orbit has gone just completely flat. Usually orbit is a cone-like structure, just flat. Okay, because the eyeball was completely just lying over a floor. So I had to reconstruct all the bones. Okay, you can see the plates and screws. We have fixed all the broken bones and the jigsaw puzzle-like thing we have done and created the orbital socket. And this is the interrupter sutures. You can see the sutures are all the knots are there. You can see there is a continuous maintaining a gap to create a nice aesthetic outcome. Okay, and this is a 5-0 building suture. Okay, Provister usually blue or green, blue type blue in color, and nylons are black. Okay, 5-0, and this is the final outcome. As you can see, almost the facial symmetry is quite acceptable, and there are the permanent doses of the eye in our unit, and he is using a doses glass to hold this upper eye. Next, I am coming about the vertical mattress suture. This is a case of oral squamous cell carcinoma. Patient had a oral squamous cell carcinoma of the mandible, and you can see there is ulceration and continuous pulse discharging sinus. Okay, so we have removed all these areas. We have done the neck dissection, and we can reconstruct the areas with local flaps. These are called deltopectoral flap. Okay, as you can see, I'll show you a video here. Okay, you can see the gap here. I have taken the flap from this area, chest, and that flap is going up to the facial that defect. Now I need to close this amount of gap under tension. Okay, I need good tension. So in this area we usually put vertical mattress sutures. Okay, vertical mattress sutures. So you can see the mandible is not there. We have removed the mandible. Neck dissection was done because there are level 1 to 5 that we need to clear in oral squamous cell carcinoma. And this is the deltopectoral flap going from the chest up to the cover that outer area. You can see that is how we close the area. Okay, and this area I am talking about, this area is so, the gap is so big that we need vertical mattress suture to close the area. Okay, and that is how. Okay, and so this is the tube-like thing that is attaching from the head neck area and the chest. So we wait for 21 days so that this area get the vascularization from this area, facial areas. Okay, and for this 21 days, the vascularity will be maintained through this pedicure. So we have to keep it attached. After 21 days, we divide it here and here. And this middle portion we discard. Okay? Now coming about the microvascular suturing. Microvascular suturing is an advanced technique where we need more refinement. The instruments will be very refined. There should be magnification. You cannot see the that sutures in bare eyes. You have to use some loops or magnifying glasses you have to wear. And microvascular surgery is a most standard surgery nowadays. So in head and neck surgeries, we usually get a large defect, and local flaps like taken from the chest or these things are not sufficient sometimes. We need a larger flap to cover the area. Okay? So he had a squamous cell carcinoma of the right cheek. Okay, operated multiple times. It's a recurrent case, and you can see the defect. No nose, almost half of the nose, half of the 2/3 of the upper lip has gone. This is the soft palate. No hard palate is there. This is the soft palate. Okay. Mandible is maxilla is not there here. So it's a huge defect. So this is the tumor you can see. areas, local flaps are not ideal, or we cannot use a local flap to cover the defects. So we need microvascular or free flaps. We call it free flaps because we take the flaps from distal part of the body. It can be thigh, it can be leg. Okay. So in this area, we usually plan for a soft tissue reconstruction. So we have taken an anterolateral thigh flap. We have used an anterolateral thigh flap. You can see the skin has been marked. The length of 24 centimeter into 9 centimeter width. The Doppler was done to locate the vascular pedicle, where the vascular pedicle is or perforator is. Then we had, as you can see, this is called free flap. The two skin paddle, separate skin paddle, based on two different arteries, vessels, artery and vein. Okay. So one will be used for the outer lining, one will be used for the intraoral lining. And this vascular pedicle will anastomose it within the neck. Okay, for vascularity of this whole thing. So the anastomosis will be done in the neck with the microvascular anastomosis technique. So as you can see, the flap was placed in the defect, outer lining and the palatal lining, and the reconstruction was done like. Okay, as you can see, whole defect was covered. Seven days after. And now I will show, this is my last case of your presentation. Then we will go for the hands-on photography. So this is a thing that this is a fibular flap, free fibular flap. We usually prefer when we resect the mandible or maxilla, we resect jaw, we need a body reconstruction. So we take bone with the skin or muscle, whatever we need, from leg, from fibula. This is a fibular skin. You can see the fibular skin marking was done. So this is a layer by layer decision. This is the perforator. This small bluish area you can see. This bluish thing is the facial perforator. Based on that perforator, I will take this part of the skin. That skin will cover the defect. And also I will take some bone. This is the bone, fibular bone. This is the fibular bone. Mandible is a carved bone. Okay, it has angles. So fibula is a straight bone. So we need to create some angle. Okay, so I am creating the angle with discarding some triangular piece of bone from here. You can see, and it will bend like that, and it will become an angular bone. Okay, so this is the mandible, and this is my template. Based on this template, we usually shape the mandible. And this is the neck vessel. you will notice that when I remove the clamp, how the blood is flowing through this anastomosis. Nice. Okay? That is important to keep the vascularity intact. So that the flap, you can see, I will say the blood is nicely flowing through this canal. Okay? So my anastomosis is complete. Okay? And this is the post-operative result. There is no mandatory. This part of the jaw, is stipular bone. You can see how nicely we can achieve the symmetry and the occlusion, and the patient is walking no problem.